Happy New Year, everyone. Welcome to 2025. Today, we're going to be convening the Disaster Response Collaborative, and our focus area is pediatric patient tracking and family reunification. Next slide, please. The Pediatric Pandemic Network is supported in part by the Health Resources and Services Administration of the U.S. Department of Health and Human Services as part of several cooperative agreements. The content is that of the authors and does not necessarily represent the official views of nor an endorsement by HRSA, HHS, or the U.S. government. Next slide, please. We have no disclosures or conflicts of interest. Next slide. So thanks for joining. We're on the third of the 4 focus area presentations. We're looking forward to today's session as well as evacuation, which will be highlighted on February 4th. The session's being recorded. The recording and the slides will be shared with you and posted online within a week afterwards, and we'll let you know. If you have questions, you can put them in the Q&A box or the chat box, and faculty will reply after the presentations are over. Just to make sure that everybody knows, for those of you seeking CE, you need to attend the live session, confirm your attendance in the chat, add your name and the type of CE that you want in the chat, and then stay till the end and complete the session evaluation. And then at the end, I'll give you the information that you will need to use to go into your account in the CE platform and add the code and such. And please get your phone out. We do have some plans to do some polls. And next slide, please. So while this focuses on virtual tabletop exercise opportunities, I wanted to emphasize that DRC team leaders around Thanksgiving received information about a survey that we want you to complete. And it not only asks you about opting in to the VTTX opportunities that we are hosting and that are free and a benefit of this collaborative, but it also is the time when you announce what your focus area is. And that's very important to us. So we planned to keep this open through the end of January, but since evacuation is being discussed on February 4th, we've been asked and have agreed to keep the survey open until after that evacuation session. And then we really do need all teams, whether it's the team leader or a designee, to complete that short survey. It's like 8 questions. It won't take you very long. Next slide, please. This is just a map to show you where we've been and where we're going. As you can see, we're on today, reunification, and next up is our last focus area presentation on evacuation. And then after that, March and April, we will be meeting by focus area. We'll talk a little bit more about that later. Next slide, please. Here are today's distinguished presenters. And I'd like to turn it over to my friend and colleague, Christy Deutschman.
Thanks, Laura. I don't know about distinguished, but yes, we're good colleagues and this has been a great team to work with. So I'd like to welcome everybody to this session of Patient Tracking and Family Reunification DRC Focus Group Overview. Today's session will touch on several key components of hospital reunification. If your hospital chooses reunification as your focus group, those sessions will take an in-depth look at hospital reunification and will help your facility to create a reunification plan, or if you already have one, we'll look to enhance and improve your existing plan. Regardless, the key to a successful reunification plan or any emergency preparedness plan is exercising and drilling the plan. Next slide, please. Here are today's objectives. Next slide. You may recognize several names on this list from your work with the American Academy of Pediatrics, the COEs, and other PPN groups. We will have other family reunification experts from across the country joining the DRC Reunification Focus Group to help us facilitate small work groups within those specific reunification DRC focus sessions. Next slide. What is patient tracking and family reunification? Before we start discussing these components, we're going to do two things. One, we're going to need your input. So think about, what does the word reunification mean to you? And two, then we're going to hear a story about a reunification event that happened in Texas. Next slide. Okay, so this is where you need to pull out your phone or go to a different web page or whatever to open this poll. And just simply answer the question, what does the word reunification mean to you? And I'm going to have Dr. Lynn join us for this discussion and review of these answers.
Next slide, please.
Lots of different ideas of what reunification means. We were joking before this about tears. I don't see anybody putting tears or crying on here because we're not sure reunification ever happens without tears.
This is really amazing. Again, the theme of being together and family and connecting it looks like it's running strong within this group of people. So it's wonderful to see.
Minor guardian, these are all great. Thank you. Keep entering those because we're going to keep track of those for the reunification group's purposes. But we can go ahead and move on to the next slide. So before we get into, you can go to the next slide. Before we get into starting the actual discussion on components of reunification, let's hear about an event that occurred in Texas in 2024. I am pleased to introduce Trevor, and I'm going to say it wrong again, Trevor Malherbe, who is a hospital safety officer overseeing safety, emergency management, and environment of care. Trevor started this role in the adult world over 5 years ago, but in 2023, he transitioned to pediatrics at Dell Children's in Central Texas. Trevor will share his insights on an event that impacted Dell Children's Medical Center in 2024. Trevor, it's all yours.
Hey, thank you. Yeah, good afternoon, everyone. Like you said, my name is Trevor Malherbe. I'm here down at Dell Children's Medical Center in Austin, Texas. And I'm going to tell you our story about responding to a school bus mass casualty incident at the beginning of last year, how our hospital responded and how our reunification team responded. If you go to the next slide. So a brief overview of our agenda. We're going to give you an overview of Dell Children's Medical Center, how we initially responded and initially set up our reunification center. Then we're going to give you a structured overview of our family reunification program. And then we're going to finish up with recovery and mitigation, as well as lessons learned. If you go to the next slide. Yeah, so briefly, an overview of the event. On March 22nd, 2024, a cement truck collided with a school bus on Texas State Highway 21 in Bastrop, Texas. The bus had 44 pre-K students and 11 adults on board. The bus flipped and rolled completely over, landing back on its wheels. There was one pediatric death and one adult death declared on scene. And that picture in the background is an actual picture from the event, and you can see the damage that the school bus received and how in the extent of the rollover. Go to the next slide. So a brief overview of Dell Children's Medical Center. So Dell Children's is a part of Ascension. And in Ascension, Texas, we have a total of 14 hospitals. 2 of them are level 1 trauma centers. Dell Children's is our level 1 pediatric trauma center. And then we have an adult level 1 trauma center a few miles down the road. Ascension, Texas currently employs 11 emergency managers with 1 position open. So Dell Children's is a little bit of a unique situation where we have 2 campuses physically separated about 20 minutes apart. They're on the same hospital license, but have different trauma level designations. So Central Campus, which is the original campus, is licensed for 299 beds. 45 of those are ED beds, and it is the only level 1 pediatric trauma center in Central Texas. North Campus, which opened about 2 years ago, is licensed for 36 beds with 18 total ED beds and is a level 3 pediatric trauma center. Now, while both campuses did respond to this event, we're going to primarily focus on Central Campus's response. Next slide. So moving on to response, go to the next slide. So setting the scene, here in our region, our primary initial notification for mass casualty incident events is in conjunction with EM Resource and our local healthcare coalition. EM Resource is an application that our region uses to display hospital information, bed availability, things like that. But also one of the things it can do is send out alerts for different things. And one of those things is mass casualty incident alerts that our healthcare coalition organizes and sends out. And that was our first initial notification for this event. So we received an event saying that there was a mass casualty incident in Bastrop County. It was a school bus crash with roughly 55 people on board. Now, if you look over on the left where Dell Children's is pinned, that is Austin, Texas. Dell Children's is located just north of downtown Austin. And over there on the right in Bastrop County, that is where the school bus accident occurred. It's roughly about 20 miles as the crow flies, which gave us about 45 minutes to prepare from when we had initial notification of the event until we received first patient. And if you go to the next slide, this is what we did initially upon that mass casualty incident notification. We called a internal code triage level 1, which is our internal code saying, hey, something has happened, an event that is going to cause us to need more resources and expect an influx of patients. Right there, that triggers our Family Reunification Center to be activated. We also activated our Hospital Incident Command Center. We staffed an ED labor pool. We activated our Network Incident Command Center. We had a CATRAC liaison come on site. CATRAC is the Capital Area Trauma Regional Advisory Council. It's our local healthcare coalition. They help us liaise with other healthcare entities, the city, as well as the Regional Family Reunification Center. So at this time, we also stood up our own site reunification center. And then a little bit later in the event, a Regional Family Reunification Center was activated, which at this time was a local school about 30 minutes away. If you go to the next slide. So getting into our own Family Reunification Center system and how we have it set up, if you go to the next slide. So our Family Reunification team is really run by our Child Life and Expressive Therapies team in conjunction with our chaplain services and social work. So our Child Life team is made up of approximately 50 staff, and our Child Life director, along with our Child Life Emergency Management champion, really helps run and own and facilitate the Family Reunification Center program. So all 50 of those Child Life staff, they all have some base level knowledge of how our Family Reunification Center works, and they have enough base knowledge to at least get the ball rolling until we're able to call more staff on site. They also have a very robust call list structure to ensure 24/7 support. So if an event occurs at 3 in the morning where we have minimal staff on site, we're able to quickly get more Child Life staff on site to help run Reunification Center operations. Not only that, all 50 of those staff members actually have their own call list structure memorized of who they need to call. And I've seen them recite it all, and it's very impressive. And then we do ongoing education and tabletop exercises. We do Family Reunification Center specific exercises with our Child Life team. We also have a MCI tabletop and an MCI exercise coming up in the next few months. And one of the main things that we are focusing on is family reunification. You go to the next slide. So this is the physical layout and structure of our reunification center and what we use during this bus MCI, with one difference which we'll talk about. So we have our patient reception area, which is located in the emergency department, our family reception area, which is located in the auditorium, our verification center, which is in our surgery waiting room, our discharge lounge, which is in our 3 North playroom, our consultation room is in conference 2, and then our incident command center is in conference rooms 3 and 4. And we're going to dive into these a little more in the next few slides. If you go to the next slide. So focusing in more on our patient reception team. So this team is in the ED. It is their job to help receive the patients coming into the emergency department and take down their information. So that form on the right is the actual form that we use in our emergency department. And what we're really looking for is to get basic patient demographics and information. We're also looking for a little more specific stuff, things that we can use identifiers. So, not only the name, also what are your parents' name? Where are you from? Where do you live? Do you have siblings? What are their names? Do you have pets? What are their names? And this is all identifying information that we can use to help later match them. So another thing that this team in the ED does is tracks patient movement throughout the hospital. So they actually have a separate tracking form that, say a patient comes in and they have to go to the OR, they will be noted at 12:34. This patient went to the OR, so we can keep track of all our disaster victims throughout the hospital. Now, we actually have enough child life staff that our child life staff who are normally assigned to the emergency department, they continue that normal role and help support patient care, while we recall child life staff from other areas in the hospital to help fill this patient reception role. Now, we have binders and vests staged in the ED for these child life staff responding down to the emergency department. And in those binders, we have job action sheets, a brief overview of what they need to do. We have some office supplies, etc. And then we have the patient identifier form on the right and the patient tracking form, which I mentioned. We also have bright green vest staged with them as well. And they wear those. So when you go into a busy emergency department responding to a mass casualty incident, you can instantly look in and see, yep, these are my family reunification people. These are who I need to talk to. And then once the form is filled out, it is sent to the verification center. If you go to the next slide. So on the other end of the house, we have our family reception area. And much like the patient reception area, we are trying to gather information to help reunite these families. And this is our form that we use pictured on the right. And again, we're looking for much of the same stuff. We're looking for, the child's name, any identifiers, as well as the parent's name and identifiers. And then once that form is filled out, we send that to the verification center as well. Now, our family reception also does a couple of other things. They're the ones who actually physically organize the reunification once a match is made. They will walk with the parent down to where the child is, or if they're at another hospital, we will give them directions to get to that hospital or location or wherever they are. They also liaison with our incident command center. Our family reception room is specifically about 30 feet down the hall from our incident command center because our reunification team leader lives in the family reception area. So they're in constant contact with our leadership. And then we also have a supply cart staged as well for this team. And in it is the same stuff. It's got a binder with job action sheets. It's got all the forms they need. It's got, office supplies, and it has the vest so we can automatically identify who our family reception team is. If you go to the next slide. So once we have a form filled out from the patient reception area and the family reception area, they all get sent to the verification center. And this is where we are looking to make a match to match up the patient with the family member looking for them. And then once that match is made, they message back to the family reception area where they can inform that parent and then take necessary actions. Now, we have our verification center strategically located in our surgery waiting area, which is in the middle of our emergency department and our auditorium. So it's very important that the logistics work out. We're not running all over the hospital to make all these connections. So we purposely put it in the middle of the 2 different entities that are going to be coming to the verification center. And if you go to the next slide. So our last 2 pieces of the puzzle, one is our discharge lounge. And the point of this is to provide a safe space for discharged patients who do not yet have caregivers on site. And we chose our 3 North Playroom because, one, logistically, it makes sense. It's next to our emergency department. It's on the same floor. It's easier for wayfinding. It's also one of our bigger playrooms, and also it already has toys and distraction items. We also bring up snacks for them, and also we make use of our therapy dogs. We have 5 or 6 full-time therapy dogs that work 40 hours a week. They have their own badges, and yes, they have their own pictures on their badges. And this is really about, providing a safe space for these patients who have just gone through a traumatic experience. They don't have their parents or guardians, and so we're really just trying to care for them in a way that makes them feel safe. Now, lastly is our consultation room. We did not have a consultation room in our plan during this event, but we now have it in our plan because of this event. So the idea of a consultation room is to provide a private area for consultation of adverse events with a family. Say a family comes to our hospital looking for their child, and their child was critically injured, or maybe they passed. Well, we want a private space to speak with those parents, those guardians, about their child's condition and next steps, and usually our chaplain will lead this service. And this room can also be used for private reunification if that is required as well. If you go to the next slide. So I want to talk about how our Reunification Center is integrated into our region. So firstly, we are directly integrated with other Ascension Family Reunification Centers. If there's a mass casualty incident, all of our emergency managers, we are on the line together, we are tied at the hip, and it's really easy to call over to one of our own sites and say, hey, do you have this patient here? Do you have this family here? Okay, we'll send them over that way. We're also directly integrated with our Ascension, Texas Incident Command structure. Much of the same thing from a regional perspective. We're also very connected with CATRAC, our local healthcare coalition. Usually during MCIs, they will send someone on site to help us liaise with the Regional Family Reunification Center, as well as entities outside of Ascension and local government. And lastly, we use Pulsera. Pulsera is an application that we use to encode all of our patients during regular business in the field, so EMS will encode them in this application. Then our emergency department can immediately see what patients we are getting, and what their condition is, et cetera. One of the things they can do is take pictures, upload face sheets, and this has great potential for family reunification. And it's still a new tool to us, and we're working through it, but it has really great potential for family reunification. If you go to the next slide. Moving on to recovery and mitigation. So we hot washed this event a lot. We did a site level internal hot wash. We had an Ascension Texas emergency manager hot wash. We did an Ascension Texas leadership hot wash. We had a CATRAC regional hot wash involving our hospitals, first responders, emergency managers, EMS, et cetera. We have a monthly emergency management committee that focuses on process improvement. And then we have issue-specific work groups that are subcommittees of that committee to really hone in on specific issues. And then, like I mentioned, we do tabletop exercises and full-scale exercises. And we have a few coming up focused on MCI, and part of that will be family reunification. And if you go to the next slide. Lastly, I want to talk about lessons learned. So our biggest issue during this event was Pulsera challenges. It was a brand new tool to us. We had been using it in our region for, I think, 4 months at this time. We couldn't see pictures. We could only view patients that were encoded to our hospital. It works different in MCI. So that was really the biggest struggle for us. But it's a great tool, and I really advocate for it. Next was traffic flow of families. We needed to designate staff in the emergency department to direct them back to the Family Reunification Center. Usually when a family shows up looking for their loved one who is hurt, they're going to show up to the ED. So we need to have someone to bring them back to the Reunification Center, but also we need to have external signage rerouting them away from the emergency department. And then in general, we needed better wayfinding, throughout the hospital to help our, families coming to the hospital navigate to the Reunification Center. Also, language services, it was too loud in the emergency department to be effective. Our MARTIs didn't really work in a busy ER responding to an MCI, and now we're looking at including in-person interpreters into our family reunification plan. Our family reunification structure, we talked about this, but we needed a private space to discuss situations with parents and designate a private room for matching families if needed, which we have done. We're also working on ED distraction kits. During this event, it was one of our child life team members sole job to run around and give a teddy bear to every kid to help distract them. So we are looking at creating distraction kits to go along with their vest and their binder, so they come respond to the ED. You put your vest on, you put your fanny pack on, you grab your binder, and you're good to go. Regional challenges. Our regional family reunification center was too far away. It was about 30 minutes, which it is a regional event. It has to service the whole region, but it was still a little bit of a challenge for us. And then also we are working to be more integrated with our regional plan. It all worked out, but I feel like we need to work better with our region and their partners to have a more comprehensive reunification plan. And lastly, our wins. Our reunification center was activated quickly and was effective. Our food and nutrition team really supported our reunification center. It may sound like something little, but when you have family members coming to the hospital looking for their loved ones, and you can just offer them a drink or a snack, it's the little things that really matter. And then lastly, our vests and stickers. It was super helpful to be able to walk into a busy ER, like I said, and just identify who you need to talk to and who the reunification team is. I didn't put it here, but really what I want to end with is that through all this, we're still able to provide great patient care. We reunited all of the family members with their patients, their kids, and everyone went home safely. And if you move on to the next slide, feel free to reach out to me with any questions.
Thank you, Trevor, for sharing your story with us and your experience. I think there's so much to be garnered from lessons learned from people who've actually lived that type of an incident. So thank you again for coming through. Thank you to the DRC for hosting a focus area on family reunification. I just want to mention that this is work that we've been thinking through for the past couple of years, and the DRC has kindly helped us forward our own agenda within the reunification domain. I would also like to call out our partners in Region 5 for Kids, who have also done some reunification work over the past year with their hospitals in that area on reunification, and will be kind of working together through this process. Next slide, please. So we have another poll for you to go. After hearing Trevor's story, what state of reunification is your hospital in? And we go along the pediatric guidelines here, or pediatric stages. So pre-existing as not having thought about reunification at all, to fetal, where you've considered having a plan but don't have one yet, newborn, where you're starting planning, school age, where you have a plan but maybe haven't exercised it yet, adolescent, well, you have a plan, you've tried it, it might need some improvements, to adult, we have a plan, we've exercised it many times, and we are so confident that we can respond well. So please enter your answers, and we will show the live answers on the next slide. I am really super excited that there are, we have a few who are in pre-existing state, but the majority here are in adolescence. If we could all just stay in adolescence, it might be kind of fun. All right, moving on, we'll close this poll and go to the next slide. So why should you choose reunification as a focus group? So on any given day, and today being a weekday, my child's not with me. If you have children, your children are probably not with you. There's about 67 million children who are not with their parents. They're in school, they're in childcare, they're in a camp. And when an incident happens, most likely your child or children may not be with you. And there are really kind of long-term consequences associated with delayed reunification, including decreased coping and increased risk for mental health disorders, including PTSD, mood disorder, and other things. Delayed reunification is associated with worse health outcomes and increased healthcare costs. Next slide, please. Really, children who are separated are extremely vulnerable. They're at risk for significant physical and mental trauma, neglect, abuse, and even exploitation. And so when you're thinking about reunification planning, it's important to actually include strategies that keep families together for any type of a disaster. So when we're breaking down pediatric patient tracking and family reunification, the patient tracking part is really just a structured system for following a patient or a pediatric patient through throughout your system, but then beyond through the incident itself. And then family reunification is really that process of reconnecting children with their families or guardians after separation. Next slide, please. My mom used to always say, Confucius says. So Confucius says, study the past if you would define the future. And what we do know from Hurricane Katrina and Rita, that there were over 5,000 children who were separated from their families, and it took over 6 months to get the last child reunified. And I think this was the first big event which actually sparked generalized interest in reunification and also highlighted the fact that we can do better. Next slide, please. We're going to go through a few expectations and realities. Next slide, please. In general, the public perspective is that family will obey evacuation orders, but if families are separated, 63% of them would actually disregard evacuation orders. Furthermore, hospitals need to have plans for reunification, and the public expects that we would be serving this non-medical function. However, less than half of EDs have disaster plans that address children, and this is NPRP data, which a lot of you are familiar with. And then the other thing is that families will be expecting immediate identification and reunification of survivors, but the reality is that hospitals won't have that information immediately, and that oftentimes it may take days or weeks for identification of deceased victims. Next slide, please. From the hospital perspective, there sometimes is that sense that it won't happen to us, and it won't happen to us because we aren't a major trauma center, or it won't happen to us because of insert any excuse here. But the reality is that there is always a plan for distribution of patients, oftentimes with scoop and run. And then if you actually ask a search engine, and you can insert search engine, aka Siri or Google here, where is the nearest hospital for children, or where's the nearest hospital for that cares for children, it's often very inaccurate. The other kind of thought is that, oh, we're hospitals, right? We only serve a medical function. We don't do reunification. However, over half of families surveyed will be searching for loved ones at the hospital first. And most people estimate 8 to 10 loved ones seeking missing children or family members per patient that they see. And those will be coming to your door at the hospital level. And then the last one we want to go over is that we already have a plan. If you already have a plan, that's great. Keep exercising it to failure, because there will always be a gap. All right, next slide, please. We are going to go over a very brief overview. We have over the course of the DRC, there will be time for us to delve into a lot more detail. And so this is just kind of a teaser, and hopefully will help you think about some of the essential elements of reunification. And we've broken it down into the 4 S's of space, staff, supplies, and systems. So in terms of space, there are 4 areas that we generally think about during reunification. One is a pediatric safe area, and that is where you house medically cleared patients or uninjured victims in an area that's away from medical care. And here you'll want to ensure that you have controlled ingress and egress into the area, as with the other areas as well. The second area is the family reception area, and this is when families present to the hospital. You will want a place to actually receive those families, to actually allow them to share the information that they have so that we can ensure reunification with their child, or unfortunately give notification of death if we're able to. And so you want to have an area to receive those family members. This space, you'll also needs to take into consideration that these families may be bringing other children with them. And so there needs to be provision for childcare in this family reception area. The third space is a reunification area, where the actual process of reunification happens, where you're bringing families and their children together. One of the things that needs to be considered is that you don't want to do this in the family reception area, because there may be families who are still searching for loved ones or who have been waiting for a long time, and that could be challenging for the hospital. And then the last area is a media area, where you can interface with the media and send out general messaging to the public. And again, that needs to be separate. Next slide, please. So supplies, we're going to focus a little bit more on the pediatric supplies of things. And so distraction techniques, as Trevor had said in his previous talk. So toys, arts and crafts, and games. And I'm going to highlight tablets a little bit. I know all of our kids probably play with tablets to some extent, but really in a survey done by one of our PPN scholars, she actually found, after surveying parents of children with autism, that tablets were one of the primary ways of calming their child in a setting that may be unfamiliar, a good way of distraction. You'll want to have age-appropriate nutrition, whether it's formula, pureed foods, and also take into consideration dietary restrictions. And then definitely for the younger kids, the diapering and wipes and things like that. You'll want to make sure that you have enough supplies for hygiene for children, including additional clothing of various sizes and so many other supplies. Next slide, please. We'll go on to talking about another S, staffing, and reunification, like all of disaster response, is a team sport. There are so many people who are involved. You'll want your medical team and your behavioral and mental health team, as well as child life, security, people who, we have a school in our hospital, but if you have on-site childcare or schools, you may want to involve the staff in those areas. Nursing, social work, definitely facilities, because you're going to need to look at different spaces within your hospital. Your risk management team, communications, interpreters, and other such folks will need to be involved in planning. Another note on this is for For the staff who are actually working within the pediatric safe areas and the family reception center, it would be nice to have mental health training for screening and psychological first aid, because a lot of these incidents will incur mental trauma. Next slide, please. And then the final S is systems. Having leadership and organization structure for reunification planning is essential, and also aligning that structure with what already exists for your disaster responses within your institution. There's processes that need to be really delineated and detailed out, including the process of family intake for when a family arrives to ultimate reunification or death notification. Additionally, there's a separate but parallel process for the unaccompanied minor from registration to reunification. And then other processes that you'll need to think through and plan for are information sharing with external partners, legal considerations, and communications. And I put in an extra bullet mark for external partners, because it's really important that if your community has a reunification plan, that your reunification plan within the institution aligns with theirs. And it's important to build those relationships earlier. Next slide, please. So after we've gone through the 4 S's, for reunification planning, which area concerns you most about reunification planning at your institution? And this is a poll, and we are going to force you to make a choice. You can't choose more than one. This is a single choice, multiple choice question. So space, supplies, staffing, systems, none of the above. Our reunification plan is robust. And it looks like staffing is the biggest concern at this point. We'll give it a few more minutes. All right, I think staffing is winning, and the polls are slowing down here. So I think we can move on. The next section will be facilitated group discussions. We will spend about 15 minutes in facilitated group discussions here. And we'll have a facilitator for each group. And we'll also be using a Padlet, which is an online whiteboard for this discussion. So the case scenario is a school bus versus train MCI about 5 miles away from your hospital. There were 25 preschool children and 4 adults on the school bus. You have received 11 children, 7 with minor injuries, 2 with moderate injuries. 1 was critically injured and sent immediately to OR for stabilization, and 1 child died on arrival. You are expecting an additional 7 uninjured children to arrive soon. And then the questions to discuss within your small group is, what reunification challenges do you foresee? And how would your hospital respond to this situation? The QR code on this slide is for the Padlet, which is our online whiteboard, and you can feel free to add your own responses there, but facilitators can use this to actually document and record discussion highlights for a report out. Thank you. Julie will be breaking you out into small groups shortly. Sorry. Is this better?
Yes.
Hi, welcome back, everybody. Hopefully, you guys had really active discussions going on. I'd like to invite the group leaders to kind of come through and report back. We have been tracking some answers on Padlet, and hopefully that will be we can share that as well. How many groups did we have?
Amy, let's start with those on screen. Can we start with Tracy or Annette, please? And what your group said, and then we're going to Jill third.
I'm happy to jump in. Sorry, Tracy, if you like had something.
Okay, I'll go after.
Oh my gosh, I got to get in first. I thought what was interesting in our group, but at least the one thing that stuck out to me because it ties into that really high chart on the polling about staffing, is that because there's been such a staffing turnover, then finding plans that were maybe in place prior or during COVID can sometimes be a little challenging, finding all of the work that's already been completed. It may be that there's a decade of work done, but where is it stored, and do we have everything? And I thought that was interesting as one of the greatest challenges, at least for that particular place, in regards to reunification, finding those plans from staff that have turned over.
Hey, we had some great conversation. One of the challenges that was brought up was that, it may depend on the size of the hospital, and also if there are other hospitals nearby, how well prepared are they for the number of patients coming in, and also if there could be more fragmentation amongst the response. So, for example, we had a participant in New York City who said there's so many hospitals within a small radius, it can be really challenging to predict where patients may end up. And then it's also hard to coordinate that reunification process. There also can be physical space concerns, so flow of traffic if there's multiple entry or access points, especially for larger hospitals, and trying to make sure that we're capturing all of the families entering as well as patients entering and getting them where they need to go, with some suggestions of things like posting signage outside, people finding that hospital security, or resources for having physical people to help direct can be really helpful. We also talked about language barriers and potentially, having those distraction kits or different resources be available in multiple languages or interpreter services as well. And just a unique perspective thinking about, is there an opportunity to maybe educate the public pre-event so that families can understand, that what the hospital might be doing and preparing for. So if something does occur, they can kind of be more, prepared or anticipate what to expect, which I thought was an interesting way to look at it.
Jill, are you still there?
Yeah, I'm here. So we had a great conversation, and it sounds like a lot of collaborating between different hospitals just to try and kind of learn some best practices from everybody. One of the, kind of echoing what was discussed in the original session, but there was a lot of conversation around ensuring that the appropriate kind of like parent to child was matched, that ensuring the custody was covered. And one of the solutions for that was just pulling in the school personnel, which I saw mentioned several times within the hospital response column, was school personnel should know exactly who is the appropriate person to pick up those kiddos in this event. I did note that Trevor had made the comment about how in the Q&A about how some of the kids did not actually have identification on them. So you would also need to ensure appropriate identification, which was discussed in our group as well. I think the primary thing that we started with was just talking through, like, technically, if in a perfect world, if you activated Hicks and you activated your reunification plan, everything should go smoothly after that. But that's not necessarily always the case, and really kind of knowing to exercise those plans just to find any gaps or figure out what you might be missing as it actually plays out.
Thank you. Nathan, are you there for group 7? We might need to unmute him. Nathan Tim.
Can you guys hear me?
Yes, we can. Go
All
ahead.
right, cool. Yeah, hey, I'm the representative for Group 7, and a lot of what we discussed, the other folks have brought up. So just to reiterate, Jill brought up the stuff about having that school representative on hand, and hopefully that's something that can be coordinated because they often are the ones that really know who these children are and how and who the right parent is. The other thing that we talked quite a bit about up front is just how do we, in general, enter kids into our system, whether that's an electronic medical record or paper charting, and just the complexity that can occur through the using paper charting versus using a state name or some other designation for a child where you don't really necessarily know their name. And these kids being preschoolers, you never know what their level of familiarity is with that. And just that sort of the complexity of just doing that within each of our systems. I think the other thing that we also talked about was just the really hard decision making around the child who went to the OR or the child who died, especially there when there's no identification of that particular child, and how do you get to the point where you've now identified who that kid belongs to or who that child belongs to. And then there was also some, the topics which the school can help with in terms of the guardianship and, who is a parent that actually has legal guardianship or custodialship over that particular child could certainly be useful from the parent standpoint. And then the last thing would be the sort of relationship between the hospitals in a community where there are patients going to different areas. The 4 adults could potentially be parents of those children. How are those lines of communications back and forth between the hospitals? What does that look like? And a lot of times these systems are things that we do every day, but just now it's going to be much more highlighted and tragedy associated with. So thank you on behalf of Team 7.
Awesome. I've just been reading through the notes and stuff from here, and a lot of people have concerns and challenges about staffing, where they're going to pull from. And then in addition to staffing and stuff, making sure you have people with the right skill sets to staff those different areas that are needed for reunification. Hospital response, everybody there was a lot of open incident command, either full or partial, reaching out to the schools and involving the community, involving the healthcare coalition, public health, etc. There was a lot of questions and concerns about data collection. What data do you collect? What data is best to collect, etc. So all of those things are great questions and great concerns. And part of the exercise of doing this was for us as the reunification group. So we're going to be taking these questions, concerns, and be answering those specifically in our reunification sessions. And we'll discuss in detail all of these things. Anna, what else would you like to add before we turn it back over?
I want to thank everybody for your active engagement in this. There's so much to talk about, and we all know that reunification is really complex. We're hoping that you guys will choose to work with us over the course of the DRC collaborative. And we'll see you hopefully in the next month or so too. Thanks. Next slide. So after you've had a chance to have some group discussion after our presentation, we're going to do a retake on this. This is kind of like a pre-post. So after all that you've heard today and discussion, what is the state of reunification at your hospital? And so this is our take 2 on this poll, just to see have things shifted. As the responses are slowing down, it does look like we shifted from mainly adolescents to going back to school age. So I think we've had some developmental regression after this session, which it's always eye-opening to hear other people's experiences to actually share with each other. And so thank you for sharing your thoughts on this. And we will close this poll and move on to the next slide. Thank you. I'll be handing this over to Dr. Eisenberg for his additions to this presentation. Thank you.
Thanks, and thanks to everyone who has joined so far and who has spoken. It's been great. So just people who have been on these before know that we're trying to, as much as we can, integrate mental health considerations into every presentation and every planning exercise as possible. And we have a mental health domain within the PPN, and we have some mental health representatives who are actually on this call right now if there's any further questions. But some of the mental health considerations regarding reunification that they wanted to assure that we mention. So the first one being the additional risk, including PTSD, depression, anxiety, and prolonged grief disorder for children who have been involved in these types of issues. And it's something that we've touched on so far. And then kind of a plug for SciStart triage system for a whole child approach to trauma-informed care and the National Children's Disaster Mental Health Concept of Operations. We'll put links to all of this if possible. SciStart is a program through the PPN. We'll be discussing it likely in a month or two in a little bit more detail, but hopefully a lot of people have already been involved with it. And then sort of a plug to develop, train, and exercise protocols for psychological management and support of a whole list of different types of unaccompanied minors, injured children with no surviving family, children with history of prior trauma or loss, admitted patients, those with concurrent psychiatric diagnoses like autism spectrum disorder. They're all going to require a slightly different approach. So having protocols, but also training your staff to be prepared for those type. And within training staff, it's not just preparing the staff for the children, it's also preparing the staff in psychological first aid for the staff who are interacting with these MCI issues and direct patient care and contact. We've had a couple talks already in the past couple DRC lectures about frontline workers who have undergone pretty significant traumatic issues and sort of the aftermath and the after effects. So also, again, a plug for SciStart and the Anticipate, Plan, and Deter models. And then there's been a lot of discussion about engaging our community partners. The Family Action Network is FAN. As part of the planning and drills, every local EMSC has contacts out to those. So making sure that when you're planning your drills, you're engaging with all of your community partners and making sure that the family networks are also engaged. And then developing linkages with those governmental agencies, both from a city, county, and state level, responsible for unaccompanied children, for coordinating these what can be very large reunification efforts and strategies, both from the independent school districts to family advisory. Thank you, Pat. The school districts to the local preparedness centers. And then considering establishing a pediatric safe area and or a family reunification center childcare area that offer activities that promote emotional and behavior regulation while providing an area separate for ongoing FRC activities. And we had a quick discussion about this in our group, sort of people who are doing different things within an FRC and the ability to kind of separate out those groups, space allowing, was something that could be very important for psychological safety of everyone involved. All right, next slide. So this is just an update for what else is going on in the PPN. We have the PPN, this is a bit of a mouthful, Pediatric Disaster Preparedness Self-Assessment for Children's Hospitals, PDPAC. This is something that's been in the works for quite some time now, involving the QI domain, the evaluations domain, the analytics domain, as well as a lot of subject matter experts. This is going to be a recurring inaugural national assessment to establish a baseline to measure pediatric emergency, disaster, and pandemic preparedness among children's hospitals. This will go out to all of the children's hospitals that the PPN is working with. So it's going to be 187 different children's hospitals. This will serve as a baseline for the DRC and focus group areas to a certain extent. So you will receive a copy of questions and instructions later this month. And then options are available to identify who from within the children's hospital has the understanding and knowledge to fill out each of the topic areas. And once all sections are complete, an emergency manager, medical director, or leader can review those and submit. There will be multiple areas within the questionnaire. So different area experts within your hospital system can answer those questions and then return them back to the leader. Teams will have 1 to 2 months to complete, and then assessment analytics will be provided to guide the DRC focus areas, and then future assessments can guide improvements over time. So this is a exciting but also very large-scale project that will give us a little bit of baseline information to help with focusing our DRC efforts. Okay, next slide, and then we can get to some questions. So just upcoming sessions, February 4th is going to be our evacuation focus group session. And then March 4th is a focus group session. You'll note different times. So 1 to 2 p.m. is going to be surge capacity and the triage, infection control, and decon groups. And then 2:30 to 4 is going to be evacuation, pediatric patient tracking, and family reunification. And then April 1st, go back to the focus group sessions. May 6th, we come back for a collaborative session. Okay, and then I think there might be just a wrap-up slide. Great. So this is just the continuing education, make sure and claim credit, text the different numbers or go through the PEDS Pandemic Network code. And I see that there are a couple questions. So if somebody from the reunification group wants to potentially take these, I think we've got just a few minutes left. I saw one, is there any guidance associated with kids on the spectrum to help de-escalate them, as these events can trigger aggressive tendencies that can be difficult to manage? So I'll open that up to either the reunification group or any of the mental health folks that I did see on the line.
I don't have anything specific, but I know it's part of our toolkits and stuff to have considerations for those types, for all the different populations, pediatric populations. So specifically, no, but Anna's popped on, so I'm hoping she has something specific.
So Chip is right. I think there is a de-escalation package through the EIIC. We do have a PPN scholar who actually recently surveyed parents of children with autism as to like what things would be helpful. Having quiet spaces, noise canceling, headphones, use of tablets for distractions, and then trying to put children who are not who don't do well in crowds into a smaller space with fewer people are among some of the strategies that you can help in terms of calming and distracting patients who are not neurotypical or who are neuroatypical. And Chip is putting in a bunch of wonderful resources in, but those are planning considerations that need to be brought into account as you're going through the process, because you'll need extra staff and hopefully staff with expertise to manage. So thank you for that question.
Yeah, it's a great question. And then thank you, Chip, for putting in all of the resources. We'll try and send out those resources and post them as much as we can. There is a plug for both the latest podcast from Dennis Wren, the Ready Prep Go podcast, which has been great. And if you haven't listened to past episodes, please do. And then just two more things. The QI domain sent out a questionnaire. It's very short and very easy to answer, asking kind of what area you're going to be going into. If you don't know yet, that's totally fine. But just keep an eye out for that and start having the discussions with your group as to who's going to be the evaluator and the facilitator if you're doing the virtual tabletops through the DRC, because there is some training coming up in February and April, I believe. So keep an eye out for that. Keep in contact with your teams, and then if everyone could just fill out that post survey, that would be great. And if there's any further questions, you can always reach out to the QI collaboratives. You can reach out to any of the speakers who posted their emails, and yeah, let us know. Thank you so much.